Hello and welcome to the first of the lower GI tutorial series on appendicitis. My name is Dr Mona Panahi and I'm a foundation doctor currently back home in Yorkshire, having completed my undergraduate training at Imperial. So in this lecture series I want to discuss common conditions that you'll encounter in general surgery. So we'll go over the pathophysiology of appendicitis and the differential diagnoses of acute abdominal pain. As a foundation doctor, you will almost certainly encounter appendicitis. It affects 10% of the population, and so you'll see it in A&E, GP, or on acute surgical takes, where as a junior, you'll be expected to clerk in patients, refer to you, and begin some basic investigations and management before presenting findings to the registrar. We will also discuss the complications of both appendicitis itself and also postoperatively on the wards. So to begin with, appendicitis is the inflammation of the vermiform appendix. It's a finger-like projection found between the ileum and the cecum. The commonest causes are fecaliths, but also lymphoid hyperplasia after an infection. Rarely you have worms, and in older patients you should always consider a blockage caused by a malignancy. Now, regardless of the cause, once the obstruction has occurred, there's increased intraluminal pressure as there's continued mucosal secretion causing edema. The pressure builds up and can place pressure on the walls of the appendix. The gut microorganisms that are already here become trapped, proliferate, and cause inflammation. As the pressure builds up, compression of the nerves causes pain, and compression of the vasculature causes ischemia and necrosis. Alongside the increased pressure and weakened stretched walls, this can lead to perforation, so it's important to intervene early. So a young patient will present to the surgical assessment lounge complaining of abdominal pain for the past couple of days. It can be colicky, and they'll often tell you it started in the umbilicus and then became worse before migrating to the right iliac fossa. This is one of the strongest indicators of appendicitis as a differential. She also states she feels nauseous and had an episode of vomiting yesterday. Nausea is very common. Vomiting, you can get 1 or 2 episodes, but if it's constant vomiting, it's unlikely to be appendicitis. Often there isn't any change in bowel habit. However, some patients can have a history of constipation, which could be the cause of the fecalith, or diarrhea caused by irritation of the rectum from a pelvic appendix or from a pelvic abscess. So on examination, she's febrile, so a low-grade fever is common. Signs of dehydration, and she hasn't eaten or drank anything for the last couple of days, feta oris, and she's tender over McBurney's point. McBurney's point is the approximate location of the appendix. It's found 1/3 of the way between the anterior superior iliac spine and the umbilicus. Rosving's sign may also be positive, which is where palpation of the left lower quadrant produces pain in the right because of stretching of the peritoneal lining. If there has been perforation of the appendix, there will be guarding of the abdomen, best demonstrated by percussion. A localized perforation can occur, so there could be guarding and severe tenderness locally. However, this could also be general peritonitis of the entire abdomen. So pain can be atypical due to the different positions of the appendix in different people. Other special tests to demonstrate the different locations could include psoas sign and Cope's sign, also known as the obturator test. With the psoas sign, the patient laying supine will have pain on extending the hip. This is due to irritation of the rectal sheath from a retrocecal appendix. With Cope's sign, pain is elicited upon flexion and internal rotation of the right hip. This would be suggestive of an appendix lying deep in the pelvis or retrocecum, causing irritation to the obturator internus muscle. a digital rectal examination isn't indicated. However, if present, would suggest a pelvic appendix as well. Investigations you would routinely perform would be a set of observations, a urine dip to rule out a UTI or pyelonephritis. However, it's important to note that sterile pyuria can occur from bladder irritation in appendicitis, and ketones are often raised from anorexia. A urinary pregnancy test is vital in all women of childbearing age to rule out an ectopic pregnancy. In general, it's a very useful test in all women presenting for surgical assessment. General bloods include a full blood count, should be performed, and CRP as well. This could show elevated white cell counts and CRP if the appendix is inflamed. However, these can also be normal. BCP, or alternatively LFTs and Usenes, can be performed to have baseline bloods and also to rule out any other pathologies. Amylase may also help in that regard. For surgical patients, it's also good practice to send a group and save and clotting screen in preparation for any possible surgeries. An ultrasound scan is useful to rule out gynecological pathologies, hepatobiliary or renal pathologies, but the appendix is usually poorly visualized because of overlaying feces and gas in the bowel. However, you can see obstruction of the appendix and thickening of the walls. Alternatively, free fluid in the right lower quadrant is always pathological in males. CT can be done for older patients to rule out malignancy or diverticulosis. However, it's not usually used in the UK. Once you have presented to your registrar and the patient is admitted, there are two things to consider. Firstly, supportive management. You need to administer analgesia, antiemetics, and consider fluid resuscitation if they're dehydrated. Particularly if they're peritonitic, you should consider IV antibiotics. However, this isn't appropriate for all patients. The second consideration is preparation for surgery. Keep them nil by mouth, drug chart and VTE prophylaxis, ECG in second group and save. Patients can be kept for monitoring, and appendicitis does often self-resolve. However, due to the rate of recurrence and risks of complications, surgery is frequently performed. This could be laparoscopic or a diagnostic laparoscopy, provide a definitive diagnosis before removing the appendix, or it can be open. Laparoscopy has better post-operative outcomes such as reduced infection, rapid recovery rates, and open surgery is better visualization for quicker access during complications. Most patients are monitored overnight and discharged the following day. Sometimes the appendix becomes surrounded by omentum that adheres and localizes infection more effectively, forming an appendix mass or an appendix abscess. The surgeon would decide whether to operate immediately in these cases or consider an interval appendectomy. This is where the mass is allowed to resolve by itself, or an abscess has CT-guided percutaneous drainage, followed by an elective appendectomy 8 to 12 weeks later once it's settled. The choice will depend on your senior surgeon and local guidelines. With the weakened walls of the appendix, there is a risk of rupture, allowing microorganisms and fecal matter to escape into the peritoneal cavity. This increases morbidity and mortality, which is why many trusts have a low threshold for appendectomies, and perioperative complications we've discussed. So to summarize, this is something you'll almost certainly see as a foundation doctor. If patients are young, the appendicitis is likely to be attributed to fecaliths, whereas malignancy should be considered in older patients. In young women presenting with abdominal pain, you must always rule out gynecological emergencies. Definitive management is an appendectomy and usually has excellent prognosis. And this is some further reading if you're interested. And thank you very much for listening.